to speak about the rationale for hemoperfusion in sepsis and COVID-19 with organ support, the case for HA38 desorbent device. I'm also indebted with Jafron, who wanted to organize this symposium. It is well known the sepsis cascade is made from an original infection with recognition of LPS, opsonized and recognized by monocyte through the CD14, leading to endothelial cell activation. At this point, humoral and cellular effectors start to initiate the cascade of immunoresponse, and the final common pathway is a disruption of the immune system that may lead to organ damage. Thus, septic patients may have different therapeutic targets in different moments. At the beginning, the source control and possibly endotoxic removal could be the target. Drugs may help throughout the session, but there are no specific drugs. When immunodysregulation occurs, immunomodulation and cytokine removal seems to be the most important aspect, because it is generally and non-specific, and I will see and tell you why this is important. And finally, multiple organ support therapy can be provided to support organ failure. At the beginning, it's very well known that endotoxin level may somehow correlate with mortality in septic shock, and thus a removal of endotoxin may represent one of the possibilities. Indeed, we have dumps and pumps, and among the pathogen-associated molecular patterns that are triggers, we have LPS that can actually be targeted for extracorporeal removal. But then we have also damage-associated molecular patterns that are representing somehow the targets for immunomodulation, including different cytokines and different substances. Once again, the molecules derived by the pathogen include basically bacterial fragment and lipoproteins, while host-derived molecules represent the response of the immune system and include all chemokines and cytokines and other inflammatory molecules. Now, at the beginning, there is a pro-inflammatory response with activation of specific cytokines, and the system starts to respond with a very high level of inflammation. In the second part, however, this may be counterbalanced by a series of anti-inflammatory cytokines that may actually overcome the original inflammatory state. So, inflammation and counterinflammation are two sides of the same coin and represent the response of the innate immunity and the adaptive immunity. In this case, we know that patients may actually die lately due to intractable inflammation, while patients may also die because of persistent immunosuppression and excessive adaptive response with different immunodysregulation. Now, it depends on pathogen, load and virulence, patient comorbidities, and host genetic factors. But in general, we know that this is the situation in sepsis. And that's why the sequential extracorporeal therapy has been proposed with endotoxin removal at the beginning, cytokine removal in the middle, and organ support later on. The concept of removing cytokines is a very interesting one, and it goes back to the peak concentration hypothesis that was published back in 2003. As you can see here, you may have sequential peaks of pro and anti-inflammatory mediators, or you may even have a simultaneous activation of both pathways. In both cases, the therapies that actually designed to block and remove cytokines may actually cut the peaks, somehow restoring a certain level of immunohomeostasis. Now, the interesting thing is that a similar problem has occurred with the pandemic of COVID-19. The SARS-CoV-2 virus, originally thought to be a Chinese problem, rapidly spread out throughout the world and came into a specific jump through species from the bat to the pangolin, finally to the man. It was firstly reported by officials in Wuhan City in December 19, and then sequenced and identified at the beginning of January. Already on 6th of February, we proposed to prepare for extracorporeal organ support in intensive care because it was not possible to anticipate the extent of the epidemic and the number of patients requiring extracorporeal therapies. And in fact, the tsunami came, and we all know today that we may have patients asymptomatic or oligosymptomatic, or patients with moderate reaction, and finally severe reaction with atypical pneumonia. And radiological findings are well known, both in case of non-severe and severe clinical conditions. A typical manifestation of COVID-19 is a typical pneumonia with a very important manifestation at the pulmonary tissue level. But not only the lungs are affected by the virus, and there is, as in sepsis, a multiple organ dysfunction condition, including the heart, the liver, the kidney, of course, and also neurological and hematological system. This induces what we call the organ crosstalk, which is an interaction between different organs that actually can be somehow prevented or supported with specific therapies, just modifying the level of intensity and the complexity of the extracorporeal circuit. We know over 40 years that there's been a real important evolution in machines for doing extracorporeal therapies in intensive care. And today, we may say that the machines are actually platforms that allow all these extracorporeal therapies. We published quite quickly about acute kidney injury in SARS-CoV-2 patients, frequently observed in patients affected by different comorbidities, including chronic kidney disease. There was a specific local and systemic inflammation. And at this point, identifying patients at risk is extremely important. We suggested to use biomarkers. And we suggested to use extracorporeal blood purification techniques to somehow limit the systemic and local inflammatory response. The virus was identified in the tissue and in kidney tissue in particular. And this was a cartoon that we published in Lancet Respiratory Medicine this year, where we show that different mechanisms may lead to acute kidney injury, including endothelial damage, podocyte and tubular cell localization, acute tubular necrosis, hypovolemia due to presentation with gastrointestinal symptoms can actually affect the kidney as well. And finally, we can have three different situations. One is the typical pneumonia, which can be aggravated by ARDS and mechanical ventilation and ECMO. And if AKI develops, hypervolemia may affect both the lungs and the kidney, causing congestion. We may actually have hypercoagulable state with microthrombi, microembolism, and kidney infarction, and also this concur to the myocardial dysfunction with arterial underfilling and venous congestion. And finally, we might actually have what we call cytokine storm, which is an uncontrolled release of cytokines due to specific systemic inflammation and disruption of the immune system with endothelial dysfunction and kidney damage. Now, this cytokine storm is a reality. This paper by Zhu in Lancet shows clearly how much the level of interleukin-6 and other high sensitivity cardiac troponin and other biomarkers tend to increase in patients where there is a early lung involvement, but there is a sudden increase in different inflammatory parameters that may somehow justify drugs against these cytokines, but also may contribute to identify these patients. Now, we know very well that this is important, but do we have other options? And other options are being proposed by this article in Nature Reviews Nephrology, bringing the rationale for extracorporeal therapies, especially to remove cytokines, preventing the cytokine release syndrome. So, when infection comes, it's the same cascade that we noticed in sepsis, except that instead of having endotoxemia, we have viremia in this case. And virus removal can be an option, but not too much in this case because viremia is not so high in COVID-19 patients. While cytokines and mediators can actually be removed by extracorporeal circulation with hemoadsorption. In this case, this is the HA380 sorbent device. And finally, organ damage can be leading to organ failure and requiring organ support. Now, we can concentrate actually on the possibility to remove cytokines, especially in the moment in which there is a disruption of the dysfunction, of the immune response. Now, how is the mechanism? Exactly the same as in sepsis. Viral infection caused pneumonia, can be aggravated by mechanical ventilation and ECMO, leading to a pro-inflammatory state, responding with a counter-inflammation by the adaptive immune system, and finally leading to endothelial dysfunction, shock, and organ failure. Now, if we can actually apply a system to block the level of cytokines to a lower level, somehow reconstituted a level of immunohomeostasis, we can actually protect the endothelium and the organs. And this can be done specifically using the sorbent in conjunction with the CRRT filter, both before and after the dialysis. Measuring cytokines not always gives you the right response because of the cytokinetic model that describes very well that we don't know the generation, we don't know the half-life of these molecules, and sometimes there may be a different level of movement and transport between the interstitium and the intravascular space. So knowing this, we have proposed in Lancet how to manage acute kidney injury in patients with COVID-19, which is very similar to the way we use for sepsis. We have different steps: indications, preparation, prescription, delivery, and monitoring. We should find indication, especially in those patients where there is a cytokine release syndrome. We should prepare with specific device, including sorbents. We should prescribe the catheter, the anticoagulation, the dose, and possibly also the control of ultrafiltration. Deliver all these parameters that have been prescribed, ensuring the extracorporeal support system integrated and optimized, and finally monitoring, especially the patency of the vascular access, especially the level of anticoagulation, patient hemodynamic, and monitoring the dose. Special neutral microporous resin has been developed by Jaffron in China to remove cytokines, and the surface is particularly high in order to maximize the adsorption system. This has been used in sepsis and in COVID-19 patients with important results. In particular, once again, this can be used isolated. It can be used in conjunction with the filter before or after the dialysis. This is the case that we described, having a patient admitted with fever, hypotension, respiratory failure, mechanical ventilation, developing high level of inflammation and hemodynamic instability, being treated for 3 days with HA380 cartridge, and finally stabilizing hemodynamics, normalizing cytokine level, decreasing inflammatory parameters, and improving pulmonary exchanges to the point that on day 12 he was actually extubated. We found not only an improvement in mean arterial pressure, in decrease of norepinephrine required to maintain hemodynamic stability, and also a significant reduction, 50% reduction of interleukin-6. But we also found a somehow reprogramming of monocytes with the increase in TNF production capacity and phagocytic capacity by the monocyte that was previously paralyzed. In particular, monocytes are also expressing HLA-DR, which is the way monocytes express the antigen, and this is improved dramatically 48 hours after treatment with the use of this technique. Technique that can be used in conjunction with the ECMO, and this is how the system is organized in a parallel circuit to the ECMO circuit. And I would like to present some of the cases that have been recently presented in a webinar. This is a patient with a severe pneumonia condition by Professor Dmitry Pevsner from the National Medical Research Center of Cardiology in Moscow, Russia, where you see the treatments somehow causing a decrease in interleukin-6 and inflammatory parameters with also decrease in temperature. This is another case presented by Natachai Sriravrat on the effect of hemoperfusion. Again, he presented the case with the specific improvement and parallel improvement of PaO2 FiO2 ratio and endotoxin activity assay. So in the discussion, we have somehow proposed that the COVID-19 patient can actually be controlled by controlling the organ crosstalk with different extracorporeal therapies, by controlling the cytokine release syndrome with specific hemoperfusion, by supporting kidney with anti-inflammatory systems and membranes that can clear actually larger molecules, and supporting also the heart and other organ by providing correct ultrafiltration. In the recent webinar, there were some take-home messages by John Kellum, myself, and other presenters. There is a pathophysiological rationale for the use of hemoperfusion in COVID-19 cases of cytokine-induced hyperinflammatory syndrome. Cytokines represent possible target molecules for preventive and protective treatment based on extracorporeal removal. Studies should evaluate criteria for indication and initiation during treatment, clinical and biological endpoints for efficacy measurement. And finally, as a practical suggestion, we need to identify patients who possibly benefit, start early, monitor inflammatory parameters, and make sure you treat the patient for at least 3 days. Subsequent to that, we developed a consensus conference by the Acute Disease Quality Initiative, and that was held virtually in July this year. This is the group of experts. You don't recognize them because they all have the mask in front, but a very nice publication came out just recently in Nature Reviews Nephrology, somehow describing the process of the stage of disease, moderate, severe, or multiple organ failure, the pathogenesis, including the release of cytokines, and the treatment aim, preventing and mitigating organ damage. Target for removal are circulating mediators, and modalities include, of course, hemoperfusion. As you can see here, you can actually have different modalities, removing endotoxin, removing different cytokines, and removing hyperinflammatory the biomarkers. Again, here are the indication with the frequency, anticoagulation, blood flows, and modalities. Now, I would like to conclude inviting you to next year course in Vicenza, Italy, where we will discuss again all these topics. I think it's a very important issue. It's the future of blood purification technique, and hemoperfusion and adsorption should be carefully studied in the years to come. With this, I thank you very much for your attention.